All this fancy stuff. I'm sure I'm going to press the wrong button on this thing during the talk, so I apologize ahead of time. Well, first of all, I have to take a moment to say that it's really a great pleasure to be here for this meeting, for this event. As mentioned, I've been coming up here more years than I want to remember. It's probably been more than 30 years to VCMC and to Ventura County. And I have to tell you that it has been among the more enjoyable things that I've done during my career. I really enjoy coming up here for a number of reasons. One, because obviously it's great to be able to see patients in a situation where they don't have to travel long distances, where you can see that they are grateful to be able to get some of the care without coming all the way up here. And through the years, we tried to do that in a very limited way compared to what we can do now. But I also have to say that one of the great pleasures has been involved in teaching the residency program here. It's an outstanding family practice residency. In fact, as far as I know, it's one of the top, if not the top, programs in the country, and has that reputation. And it's really been a great pleasure to interact with the consistently great residents that you have here. And frankly, one of the reasons that we wanted to develop a program here, that we chose to develop a program here, was because of the residency program and because of the continuity that gives to the care of children in general, and certainly the kind of children we take care of. We've also had such a great partnership with the hospital pediatric and administrative leadership here, including Mike and Paul and Bob Gonzalez and the whole crew here. It's just been a great team of people. We've always had wonderful interactions. We've always been on the same wavelength about what we want to do. And as mentioned, we worked really hard with Chris Landon's prodding to develop an on-site program here, which we're very proud to have now with Dr. Bracho, our full-time person stationed here, and looking forward to developing this program to an even greater level so that we can give even more of the care for these children here on-site, including inpatient care, which we're already starting to do, and we're very, very excited about that. And again, the residency program, the whole hospital support program is very, very important to that. And finally, as mentioned, I also have to give a particular public thanks to the National Charity League Juniors, because frankly, without their support, without their rallying around this concept of having a full-time program here, we would not have this program. We needed the support of our program, we needed the support of the hospital, which was extremely important here, and we needed the support of the community, and they came forward with the community support in amazing ways and continue to do so. And it's just a wonderful partnership, and we certainly very much appreciate it, but I suspect the people who really appreciate it are the parents and the kids who benefit from this. So it's important for me to sort of give those thanks because they really are meaningful. I thought I would start out today by trying to give you a fairly quick tour through what's happened in pediatric cancer treatment and to some extent research in the past 50 or 60 years. It's been a tremendous adventure. Those of us who have been involved in this field for a good part of that time feel extremely fortunate, frankly, to have been in the right place at the right time, to be part of what has been one of the most exciting areas of medicine in the country. And I'm always fond of telling people who come up to me and say, how can you be in such a depressing field? How can you deal with this? I'm always fond of telling them that there isn't another field that I would choose to be in that has been more exciting, more rewarding, to have a group of patients who, when you start out with your career, 80 or 90% of them die, and here you are at the other end of your career and 80% of them are living. That there isn't a lot of fields that you can say that about, and at least not in the past half century. So it's been very, very exciting, and I'm sure that's true for my colleagues in this field as well. So let's talk a little bit about where we've been. Most of you probably know that cancer remains the #1 killer disease of children outside the neonatal period. Obviously, the most common cause of death in children is trauma. But as far as diseases go, cancer still is the #1 cause of death, albeit the number of deaths due to cancer has dramatically decreased over the past 50 years, as you probably know, you will see. Nevertheless, it's still the #1 disease killer. Fortunately for pediatrics, cancer is still a very small problem in children compared to adults. There are about 1.3 million people in the United States every year diagnosed with cancer. Out of those, about 12,500, actually the figure's now around 12,500, are children under the age of 20, 19 years and younger. So that's a very small number. That's great. It's still, as I said, the #1 disease killer of children. It is a problem when it comes to getting the attention of our colleagues in Washington and American Cancer Society and other organizations who are funders of research, because they look upon it this way. They say, well, this is just a sliver. There's a much bigger problem that we should devote really most of our resources to. But what they forget is that if you look at the years of risk of these 12,500 children with cancer, the years of risk if they died of their cancer, you would see that those years of risk equal the more than any one single adult cancer. So more than all the people in the country with breast cancer, or more than all the people in the country with lung cancer, et cetera. And that's because the population we're talking about in kids is very young, and the population in most adult cancers, the average age is much older. It's in the 60s, 70s, et cetera. And so we have to remember that we're talking about the very young people who, if they die, they lose a huge amount of their lives compared to adults. So I'm not saying that adult cancer is not important, but I'm saying that pediatric cancer is actually more important than some people are willing to say. Now, in terms of the kinds of cancer we see, as you know, we see different cancers in kids compared to adults. And if you look at the incidence, the frequency of leukemia and tumors of neural origin, brain, and then there's some in this other group, the neuroblastoma, some other nerve tissues, retinoblastoma, the cancer of the eye. Neural tissues and leukemia make up about half of the cancers we see in children. Brain tumors are the most common solid tumors that we see in children. And then you have lymphomas, some bone tumors, and then these the Wilms tumor and some unique soft tissue tumors and germ cell tumors that occur in pediatrics. And you obviously don't see, to any significant extent, the carcinomas that we see in adults. Carcinomas, remember, are cancers of lining cells, endothelial or epithelial. Sarcomas are mesenchymal tumors, lymphomas, obviously, and leukemias are hematopoietic. We don't see the cancers of lining cells as much, actually very rarely, in kids compared to adults. And this probably is in part related to the influence of environmental factors on those cancers, meaning smoking, diet, et cetera, whose effects take a long time to be seen. And so it's not too shocking that we don't see this in kids compared to adults. Someone pointed out to me there's an error on this slide. The incidence on the side should be per million, not per 100,000. But this gives you the incidence of childhood cancer, and you can see that there are two sort of peaks in the pediatric age range. One in the early part of that age range, 2 to 4 year old, and then another one in the early adolescent range, and then continues to go up after that. We know that the kinds of cancers we see at different age groups also somewhat differ. I'll show a slide in a minute, shows more of that. But in the case of leukemia, which is this light green line here, there's a big peak in the 2 to 4 year old age group, and there's another smaller, if you look carefully, there's a little change in the curve in the adolescent age group, a little blip there in the adolescent age group. On the other hand, things like Hodgkin's disease, which is this yellow line, bone tumors, this line here, these tend to start occurring in the preteen and teenage age range and then go up in incidence into young adults, where they become some of the most common cancers we see in that age group. So we know that there are different age ranges for these cancers.